Hello everyone. Today we are going to discuss emetics and antiemetics. First of all, we need to understand what is emesis. See, emesis, or we can call it as a vomiting. Generally, vomiting occurs due to the stimulation of the emetic, or we can call vomiting center, which is situated on the medulla oblongata. And here, always emesis could be a kind of protective mechanism which generally serves to eliminate the harmful substances which are present in stomach and the duodenum. It occurs due to the stimulation of the emetic center situated into the medulla oblongata. Here there are multiple pathways are involved in the mechanism of vomiting. The major two portions that is present in nervous system are involved into in. First, that is chemoreceptor trigger zone, that is CTZ, which is generally located in the area of postrema, and the second one that is NTS, that is nucleus tractus solitarius. Right? These two are the most important relay areas for efferent impulses that is arising from the gastrointestinal tract, throat, and other visceral organs. Here, while considering trigger zone, chemoreceptor trigger zone is easily accessible to the blood-borne drugs or any mediators or kinds of hormones or toxins. See, the basic reason is that chemoreceptor trigger zone is unprotected. It so is it being unprotected by the blood-brain barrier. Many drugs, like it could be a cytotoxic drug or any drug which are used in radiation therapy while going with the chemotherapy, or any substances which may be irritant in nature in terms of gastrointestinal tract, which could further releases 5-hydroxytryptamine from the enterochromaffin cells, and they used to act on serotonin or 5-hydroxytryptamine 3 receptors which may be present on vagal efferent, and further it sends impulses to the nucleus tractus solitarius and the chemoreceptor trigger zone. Here it is easily accessible to the certain drugs, mediators, hormones, and the toxins. Here the 5-hydroxytryptamine will be released in the large quantity, and further it will be spilled on into the circulation, and it may reach to the chemoreceptor trigger zone. Even it is from released, that is from platelets, by certain inflammatory mediators. Here one thing we need to understand that the only 5-hydroxytryptamine is not responsible behind the vomiting or emesis. There are many other peptides as well as other messengers are also involved into it. Here, chemoreceptor trigger zone and nucleus tractus solitarius expresses a variety of receptors, that is from muscarinic receptors, H1 receptor agonist, next is dopamine receptor agonist, 5-hydroxytryptamine 3 or serotonin agonist could lead to stimulate vomiting centers, right? Then while coming to the anti-emetic agents, so previous one, it may have a mechanism for emesis. While coming to the anti-emetic mechanism, that anti-mechanism or that anti-emetics are used while going with the vomiting, that is to complete cessation of the vomiting or vomisis. Here their sites could be vomiting centers. They may be activated through histamine, muscarinic, dopamine, and serotonin receptors. So, our potential sites for antiemetic mechanism will be H1 antagonist, antimuscarinic agents, 5-hydroxytryptamine 3 antagonist, and the dopamine antagonist. Emetics. How we can classify emetics? So, emetics are the agents which are used to stimulate vomiting centers, and it further leads vomiting or vomisis. Here, they may be centrally acting, that is apomorphine and the morphine. Second, that is peripherally acting, that is mustard, potassium tartrate, and hypertonic sodium chloride. See, centrally acting, they directly stimulate those vomiting centers which are present on medulla oblongata, whereas peripherally acting agents may act through gastrointestinal mucosa. And third category, that is both, that is ipecacuanha. It used to act centrally as well as peripherally. Centrally acting, that is apomorphine. Here, apomorphine can be given subcutaneous as well as through intramuscular route within 6 mg of dose. It causes vomiting within 5 minutes. So on that basis, we can consider its potency. In hypertensive individuals, however, even a subtherapeutic dose may elicit severe emesis and further leading to the collapse. Vomiting is often accompanied by the sedation, or it will be followed by the sedation due to the central nervous system stimulation. It should not be used if respiration is depressed. Large doses often produces restlessness, tremors, and occasionally convulsions can be seen. Sometimes it may cause hypotension, syncope, and the coma. Emetics that can be used peripherally. Mustard. Mustard, as we all have seen it in our kitchen, right? It is basically constituted of volatile oil. Here, it is found as a result of a reaction between a glycoside and an enzyme in the presence of water. It is safe and easily available, and the dose will be 1 tablespoon in water. Generally, mustard powder will be used to produce vomiting or vomiting. Next, that is sodium chloride. Sodium chloride can be given orally, and further it withdraws the fluid from the cells or the cell lining of the stomach, thus causing irritation, which further causes reflux emesis. Next drug, that is ipecacuanha, or we can call it as a emetic, because it acts through both the pathways, that is centrally acting as well as peripherally acting. It generally acts while coming to the peripherally. It acts through irritating gastric mucosa as well as through chemoreceptor trigger zone in case of centrally acting. It is obtained from the dried roots of Syphilis ipecacuanha, and it is available in form of syrup. It is used as syrup ipecac, 15 to 20 ml for adults, 10 to 15 ml for children, and 5 ml in cases of infant for induction of vomiting. Generally, it takes 15 minutes or more for the effect. Although apomorphine is highly effective emetic, syrup ipecac is safer. So while considering safety, syrup ipecac is safer. While coming to the contraindications with all those emetics, they all are contraindicated in corrosive, that is alkali or acid poisoning. It acts as a CNS stimulant. Drug poisoning may causes, in cases of CNS stimulant drug poisoning, we cannot use emetics. In cases of kerosene or petroleum poisoning, also it is contraindicated, and patient which is unconscious, we cannot go ahead with emetics. So they all are contraindicated in corrosive poisoning, CNS stimulant drug poisoning, kerosene poisoning, and the unconscious patient. These are the drugs which can induce vomiting. Anti-cancer drug, amiodarone, apomorphine, chloroquine, quinine, diltiazem, emetine, ergot derivatives, erythromycin, tetracycline, fluoroquinolones, and metronidazole. Here, while going with the emetics, the choice of drug will be apomorphine, which can induce its effect within 5 minutes. After that, ipecacuanha, in terms of safer drug, it can be chosen for emesis. Now, next category, that is antiemetics. These antiemetics are used in cases of emesis, where with these kinds of drug, the further fluid loss which can be seen with emesis can be reduced. Here, while going with the classification, first category that can be used as an antiemetic, that is anticholinergics like hyoscine and dicyclomine. H1 antihistaminics like promethazine, diphenhydramine, cyclizine, meclizine, and cinnarizine. Neuroleptics like chlorpromazine, prochlorperazine, haloperidol, etc. In cases of prokinetic drug, we can go ahead with the metoclopramide, domperidone, cisapride, and the mosapride. Fifth category, that is 5-hydroxytryptamine 3 antagonists, are ondansetron, granisetron, and dolasetron. Whereas in certain adjuvant antiemetics, they are corticosteroids, benzodiazepines, and cannabinoids. First category, that is anticholinergics. In that, the drug is used, that is hyoscine. It is most effective for motion sickness. See, in cases of motion sickness, hyoscine will be preferred in 0.2 to 0.4 milligram orally or intramuscular route. They may have a brief duration of action, that is short duration of action, and it may produce sedation, right? As well as certain other anticholinergic side effects can be seen, that is dryness of mouth, that can be seen with atropine. Here, it can be suitable for the short, brisk journeys, right? When person know that he or she may have a motion sickness, and in that case, is they need to go ahead with the journey, then for those short journeys, it can be prescribed. Here, even it is available in forms of transdermal patch, that is of 1.5 milligram, and it can be applied behind the pinna of the ear. It can be delivered over 3 days and suppresses the motion sickness while producing only mild side effects. Second drug, that is dicyclomine. It can be used in forms of 10 to 20 milligram orally. It is used for prophylaxis of motion sickness and for morning sickness. It has been cleared all their teratogenic potential, so it is safer to prescribe. Next category, that is H1 antihistaminics. Here, while going with the antiemetics, we may have a 5 major categories with plus 1, that is adjuvants, right? So this is second category, that is H1 antihistaminics. There are certain antihistaminic agents that can be used as an antiemetic, and they are mainly used in cases of motion sickness and lesser extent into the cases of morning sickness and post-operative surgeries and some other forms of vomiting. Here, their antiemetic actions, that is H1 antihistaminic, may have or they appear to be based on the anticholinergic antihistaminics and their sedative properties. Here, drugs are available like meclizine, cyclizine, dimenhydrinate, diphenhydramine, promethazine. Here, promethazine even used in pregnancy, and it is used by NASA, that is for space motion sickness. All anti-motion drugs are more effective when generally taken half to 1 hour before commencing journey. So before starting journey, these drugs should be taken. And once sickness is started, it means after that it is little difficult to control the condition with H1 antihistamines. In certain cases where it is already initiated vomiting, that means we need to go with the prokinetic drugs. Third category, that is neuroleptic, because they are potent antiemetics and generally they all are dopamine receptor blockers. Here it acts through D2 receptor blocking property into the chemoreceptor trigger zone, and it antagonizes the apomorphine induced vomiting. Here, antiemetic dose is much lower than their antipsychotic dose because general neuroleptics are prescribed in cases of psychosis, right? But here the major difference is their dose. These agents should not be administered until the cause of vomiting has been diagnosed. They all are broad spectrum antiemetics and effective in drug induced and post anesthetic nausea and vomiting. Is all of you may be aware about the drug induced vomiting, because in many cases where drug can be used for a longer term of duration in certain chronic cases where those drugs could be the reason behind vomiting. So drug induced vomiting can be treated with neuroleptics in certain cases of post anesthetic nausea where patient will be given anesthesia or minor or the major surgery. In that cases, after that, that is post anesthetic nausea can be found and it can be easily treated with the neuroleptics or D2 receptor blockers. Any disease induced vomiting can be treated with the neuroleptics. Even chemotherapy induced vomiting can be treated with the neuroleptics. Example is prochlorperazine. Next category and the most important one, that is prokinetic drugs. See, these prokinetic drugs basically promotes the gastrointestinal transit and it increases, that is the speed of gastric emptying by enhancing coordinated propulsive motility. Here, in case of prokinetic drug, their major effects can be seen on the gastric motility. The way or with the speed food moves through the digestive tract, that is motility, right? So generally prokinetic drug increases that propulsive motility. Obviously there are certain disadvantages with prokinetic drug because it even interferes with the absorption of other drugs as well as certain nutrients which are present in food. It should be completely absorbed, but with the effects of prokinetic drug the absorption of that food material may be delayed. This excludes traditional cholinomimetics and anticholinesterase, which produces the tonic and largely uncoordinated contractions. And the drugs are available like metoclopramide, domperidone, and the cisapride. Here, while coming to the mechanism of action of prokinetic drugs, they are potent antagonist of D2 antagonism, 5-hydroxytryptamine 4 agonism, and 5-hydroxytryptamine 3 antagonism. Remember, D2 and 5-hydroxytryptamine 3 antagonism can be seen, as well as 5-hydroxytryptamine 4 agonism can be seen. Here, as you can see in the diagram, it inhibits the effects of D2 receptor and the 5-hydroxytryptamine 3. In cases of 5-hydroxytryptamine 4, where cisapride and metopride or metoclopramide may act as an agonist, leading to the further inhibition of acetylcholine. So, in cases of 5-hydroxytryptamine 3 and the D2 receptor, where domperidone, cisapride, and metoclopramide acts and causing to further inhibition of vomiting. While coming to the D2 antagonism, metoclopramide blocks D2 receptor and increases hazening, gastric emptying, and it enhances the lower esophageal sphincter tone by augmenting acetylcholine releases. Here, lower esophageal sphincter will be present at the end of the stomach. After that, there will be a duodenum. So, generally, food moves through the lower esophageal sphincter. Due to the gastric emptying or hastening of the gastric emptying may lead to open lower esophageal sphincter earlier, and it further passes the food from the stomach to the duodenum, that is the part of small intestine. 5-hydroxytryptamine 4 agonism. Here, metoclopramide acts into the gastrointestinal tract to enhance the acetylcholine release, that is from the myoenteric motor neurons. This results from the 5-hydroxytryptamine 4 receptor activation on the primary efferent neurons of the, and it could lead in turn activate the excitatory interneurons. 5-hydroxytryptamine 3 antagonism. At higher concentrations, metoclopramide can block 5-hydroxytryptamine 3 or serotonin receptors, which is present on inhibitory myenteric interneurons and into the NTS as well as the CTZ, that is nucleus tractus solitarius and chemoreceptor trigger zone. Metoclopramide. Earlier in 1970s, metoclopramide was named as gastric herring agent, and nowadays they are widely used as an antiemetic. While considering their pharmacological actions on gastrointestinal tract, it has major prominent effects on the upper gastrointestinal tract rather than the lower tract, and it increases the gastric peristalsis while relaxing the pylorus and the first part of the duodenum. This could speed up the gastric emptying, especially in the cases of where exhalate is slow and lower esophageal tone is increased and gastroesophageal reflux is opposed. So here even GERD can be treated, because in cases of GERD, food may be present inside the stomach for a longer duration, and with the help of metoclopramide, stomach can be easily uh, that specific propulsed for the further movement of the food. It also increases the intestinal peristalsis to some extent, but has no significant actions on colonic mortality and on the gastric secretions. Their effects, that is metoclopramide's actions on central nervous system. It is an effective antiemetic and it acts on the chemoreceptor trigger zone, and it blocks the apomorphine induced vomiting. The gastrokinetic action may contribute to the antiemetic effect. However, it has no chlorpromazine-like antipsychotic property, though it does share the extrapyramidal and prolactin secretion augmenting actions of the CPZ, that is chlorpromazine. Interactions with those prokinetic drugs, it hastens the absorption of many drugs like aspirin, diazepam, etc. by facilitating the gastric emptying. It reduces the absorption of digoxin. Adverse effects that can be seen with the metoclopramide, cisapride, and the domperidone, that is, they are well tolerated. Sedation, dizziness, and diarrhea can be observed. Long-term use can cause the Parkinsonism, galacturia, and the gynecomastia. While coming to the uses of prokinetic drugs, they are better acts as an antiemetic, but they are less effective in cases of motion sickness. In cases of motion sickness, person go for the, or they should go for the hyoscine. They are gastrokinetic. They improve the functioning of the gastrointestinal tract. Even it can be given for in cases of dyspepsia, that is the cases of indigestion, and in cases of gastroesophageal reflux diseases, that is GERD. Next drug, that is domperidone. They are the potent D2 receptor blockers, and they are chemically related to the haloperidol, but pharmacologically they are related to the metoclopramide. It has lower ceiling antiemetic and the prokinetic actions. Generally, they poorly crosses the blood-brain barrier, and certain rare extrapyramidal side effects can be observed. That can be given with the levodopa or bromocriptine to counteract their dose limiting emetic actions. They are absorbed orally. Viability is only 15% due to the first pass metabolism, and it can be completely metabolized and excreted through urine. Their plasma half-life is 7.5 hours, and the certain side effects even can be seen, like dry mouth, loose stool, headache, resist galactoria, cardiac arrhythmia on rapid IV injections, but they are still less than with the metoclopramide. Okay, so what do you think? Which is a better antiemetic, metoclopramide or domperidone? As chemoreceptor trigger zone is outside the blood-brain barrier, both have antiemetic effects. But as metoclopramide can cross blood-brain barrier, it has extra adverse effects. Like certain extrapyramidal side effects can be seen with the metoclopramide administration, whereas in the cases of domperidone, it is well absorbed. So here we can overcome the central nervous system side effects with the help of domperidone. Next drug, that is cisapride. Cisapride is a prokinetic drug with little antiemetic property because it generally lacks the D2 receptor, that is dopamine receptor antagonism. Here, gastric emptying can be accelerated and lower esophageal sphincter tone can be improved. It is devoid of the actions on chemoreceptor trigger zone, right? They won't act on CTZ and it does not produce extrapyramidal symptoms. Here, cisapride can be primarily indicated in the cases of GERD, that is gastroesophageal reflux disorder. Next category, third category, that is 5-hydroxytryptamine 3, that is 5-HT3 antagonist. They are potent antiemetic agents, and even though 5-hydroxytryptamine 3 receptors are present in vomiting center and chemoreceptor trigger zone, the antiemetic action is restricted to emesis, that is caused by the vagal stimulation. So wherever in that cases of vomiting where vagus nerve is stimulated or it is involved, in that cases only we can go with the 5-hydroxytryptamine 3 antagonist. Here, it will have a high first-pass metabolism and can be excreted by liver in the kidney. Here, no dose reduction in renal insufficiency, but it can be needed in hepatic insufficiency, right? Because here, it undergoes first-pass metabolism. It can be given once or twice daily, orally or intravenously. Drugs like ondansetron can be given 32 mg per day, granisetron in 10 microgram per kg per day, or the dolasetron, that is 1.8 milligram per kg per day. There are certain indications into it, like in cases of chemotherapy induced nausea and vomiting, it can be given prior to the 30 minutes before the chemotherapy. And in cases of post-operative and post-radiation nausea and vomiting can be treated with the 5-hydroxytryptamine 3 antagonist. Adverse effects with 5-hydroxytryptamine 3 antagonist. They are excellent. They may have an excellent safety profile, may produce headache and constipation. They are the general or common side effects of it. All three drugs that causes prolongation of QT interval, but more pronounced with the dolasetron. So we can consider like it is contraindicated in cardiovascular disorders or patients suffering from the cardiac disorders cannot be given with the or prescribed with the 5-hydroxytryptamine 3 antagonist. Certain adjuvant antiemetics that can be given in to treatment of emesis. Here, first is corticosteroids, second is benzodiazepines, cannabinoids even can be given, active principle of the cannabis indica, that is the cannabinoids, and it possesses antiemetic efficacy against moderately emetogenic chemotherapy. Other drug can be given, that is dronabinol. It is used as adjuvant in chemotherapy, induced vomiting, and in cases of it is a psychoactive substance, nabilon, that is chemotherapy induced nausea and vomiting and used under close observation with certain neurological adverse effects. So this is all about antiemetics and the emetics. So today what we have discussed emetics and the antiemetics with their pathophysiology, classification of drug that can be used to cause emesis, as well as in cases of antiemetics. I have just given brief idea about the emetics and the antiemetics. Thank you very much.